Now, the Andersen-Tawil syndrome is a type of the prolonged QT syndrome. And in this, there is also prolongation of the QT interval. But this syndrome is associated with some very important characteristic manifestations. And these manifestations is, one of them is a periodic paralysis. This periodic paralysis is due to the muscle weakness that it causes, that leads to periods of weakness, and then in between some patient is normal also. So it causes periodic paralysis. Another feature associated with this syndrome is ventricular arrhythmias. Ventricles are the lower chambers of the heart. Atria are the upper chambers of the heart. The big lower chambers here, you can see it causes arrhythmias or abnormal rhythm of the ventricles of the heart. And this rhythm or impulse in the ventricle is mainly by the transmission of impulses in the Purkinje fibers. So that is affected here, and then we have ventricular arrhythmias. Then third, again, very characteristic feature is the presence of dysmorphic features. Features which are not in resemblance with each other, or they are little, size-wise, structure-wise, and mainly affect the face, limbs, and the trunk is mainly affected. So you can see this is dysmorphic features. So these are the some of manifestations of Andersen-Tawil syndrome. Again, it is a type in which there is prolonged QT interval. Now we will discuss about some EKG changes that are present in this Andersen-Tawil syndrome, and it is associated with some characteristic EKG changes. First one is the pronounced QTU prolongation. This, I explained you all those waves present on the normal EKG or the normal cardiac cycle. We have P wave, QRS complex, and then the T wave. But this U wave normally, which is not seen on the EKG because of its small size, is present in this Andersen-Tawil syndrome. And this U wave is normally present after this T wave, and U wave in this case is due to the repolarization of the Purkinje fibers. These Purkinje fibers are the fiber, if we discuss the transmission of electrical impulse, which is generated in the SA node, sinoatrial node. It goes to the AV node, which is atrioventricular node, and then from this AV node it goes to the Purkinje fibers, which are all spread in the walls of the ventricle and extensively spread into the muscles or myocardium of the ventricle. And then once the impulse reaches this, it spread rapidly and it causes contraction of the entire ventricle. Since this is the disorder associated with the repolarization, when there is defect or slow transmission of this impulse in the Purkinje fibers, that in this condition generate the U wave. So U wave is generated in this Andersen-Tawil syndrome because of the repolarization of the Purkinje fibers, and this repolarization, which is a slow repolarization, impulse is transferred slowly in the Purkinje fibers, and it gives time for this generation of another additional wave, which is the U wave. So it has prolonged QTU interval. Prominent U wave since we don't have prominent U wave in normal healthy individual, that's the one big difference on the EKG of Andersen-Tawil syndrome. Next, we have also, there is ventricular ectopy by Gemini. The ectopic beat is the beat that is coming from some other source from outside, and this ventricular ectopy, it gives the rhythm which is not normal. This is also present in this Andersen-Tawil syndrome. Then we have polymorphic ventricular tachycardia. Heart is beating fast and the ventricles are affected more. As we already mentioned, there is prominent U wave again, that is due to slow repolarization of Purkinje fibers. There is also ventricular ectopy, extra breath from the ventricle, and there is also ventricular tachycardia or fast beat, fast rhythm, which is the origin of which is from the ventricle of the heart. And there is bidirectional, both direction ventricular tachycardia. So these are a few very characteristic features of Andersen-Tawil syndrome which are present on the EKG. Now, the genetic basis of Andersen-Tawil syndrome, the gene mainly which is responsible is KCNJ2 mutation, and this is also associated with the potassium channel and is the J2 type. The prevalence is as high as 75%. It encodes for KIR 2.1 potassium channel alpha subunit. So it's potassium, this gene we already mentioned, mainly encodes the potassium channel alpha subunit. And there it is also localized to chromosome 17q23. And there is most of these KCNJ2 mutations are missense. Missense mutations are when the nucleotide arrangement is not proper, that leads to missense mutation. So these are the genetic basis of Andersen-Tawil syndrome.